Thank you very much for the kind introduction and having me speak here today. So tough task, obviously. Biology, really, we always think of as trumping everything, and particularly with lung cancer. A very, very tough cancer to treat across stages, as we know. And you're hearing about different biological aspects earlier. You'll hear them throughout the rest of this conference. But I'm going to give some insight as to how potentially radiation therapy and new ways to deliver it, new ways to plan it, can overcome some of the difficulties with biology. Disclosures are NIH and Department of Defense funding. So I'm going to split this up and look at bimodality therapy, trimodality therapy, which we just heard of, but looking at them in the context of how technology and advances over the last couple of years may improve both aspects of those modality options. And we'll also talk about proton therapy, as Corey had mentioned. So you saw this study, and I bring it up for a couple of reasons to highlight some examples. So this was a cooperative group study started now 20 years ago, recently published in 2011 in the Journal of the National Cancer Institute. And this really was one of the studies that set the foundation for why we do concurrent chemoradiation compared with sequential chemoradiation. There were 3 arms, though, and that's something that often gets sort of neglected in looking at this study. One arm was vinblastine with cisplatin, followed by radiation therapy. Another arm was concurrent vinblastine, cisplatin, plus radiation therapy. The third arm was looking at a different way to deliver radiation therapy, so delivering it twice daily. So the potential advantages of the concurrent arm is that, one, we're now able to radiosensitize the tumor cells. We're using chemotherapy to do that to potentially improve local control. The advantage of the hyperfractionated arm, doing radiation twice a day, is trying to complete the radiation in a shorter amount of time so you don't allow for the tumor to repopulate and to grow during the radiation therapy. It also potentially can lower side effects by treating multiple lower doses per day with radiation therapy. And what this study showed is there weren't incremental improvements by doing either. So compared with what was at the time standard, sequential chemotherapy followed by radiation therapy, there's about a 2-month survival benefit by doing concurrent treatment. And compared with the hyperfractionated arm doing twice daily radiation, there really wasn't any difference in survival. There were some subtle differences in failure rates, in local control, but really no major differences when we tried to exploit the biology of looking at, 1, radiosensitizing tumor, and 2, trying to deliver the radiation to avoid repopulation. This is the meta-analysis that we heard of a little bit earlier. This was 1,200 patients comparing sequential and concurrent chemoradiation, and I bring this up for a different reason as well. One thing that was identified in this study is across all studies comparing sequential and concurrent chemoradiation, yes, there was a survival benefit with concurrent chemoradiation, but there's actually no difference in distant metastasis rates and distant progression-free survival. So what this study showed was there's about a 6% improvement in local regional control at 5 years. That equated to a 5% improvement in overall survival at 5 years. So without any difference in distant metastasis rates comparing sequential and concurrent chemoradiation, there was a significant overall survival benefit. And that was almost a 1-to-1 ratio comparing an improvement in local control and an improvement in overall survival. So this gets to the point that if we can figure out how to be smart with radiation, use the technologies that we have to deliver radiation optimally, improving local control can improve overall survival. What other data do we have for that? So this is probably the best data that we have. This was done by Mitch McTay when he pulled 1,400 locally advanced patients that were treated with concurrent chemoradiation on radiation therapy oncology group, cooperative group studies. What he found, unlike the typical things that we think of for lung cancer, weight loss, age, performance status, local control was actually the significant, most important factor for predicting overall survival. And this was true regardless of how he defined local control, local regional control, and different methods that he used, whether it was freedom from progression, lack of response to treatment. So there's clear evidence that if we can improve local control, we can improve overall survival with locally advanced lung cancer. The other interesting thing that came up out of the study is the 3-year local regional control rate was only 38% across these studies. It's terrible. So essentially 60% of our patients, they're going to have their disease come back right where we treated with radiation. So this gets to 2 questions and sets the framework for the rest of the talk. 1, can we do something to improve local control, improve that 38% control rate that we've seen historically? And 2, if we do that, if we improve local control, can we then improve overall survival for our patients? This study, RTOG 7301, it was actually the first cooperative group study to look at dose escalation across any disease site. And this really showed that when we treated from 40 gray going to 50 gray to 60 gray, we had a significant reduction in local failure rates that led to an improvement in overall survival, and similarly, nearly a 1-to-1 survival improvement. So this suggests, of course, 60 gray is standard, and that has been our standard dose now for the past 40 years or so. The question is, can we do more, and can we go to higher doses? Because, of course, more generally is better, we think. Well, we saw this a little earlier, and there are a couple of things that came out of this. This was RTOG 0617 comparing 74 gray to 60 gray. What this showed is not only was more not better, more actually was statistically worse. So overall survival was only 20 months in people treated to 74 gray compared to 28.7 months in people treated to 60 gray, suggesting that potentially 74 gray was too much and that maybe some of these differences that we saw in survival was related to toxicities. What were those toxicities? Well, we're not real clear. If you look, certainly esophagitis was worse as you treated to higher doses, as expected. More patients, unfortunately, died of treatment, but those small differences don't account for why there is such a dramatic difference in survival between the two arms. And I'll speculate why there was such a difference, but before I go to the next slide, look at this statistic. So first, on the trial that we just showed, the concurrent chemoradiation RTOG 9410 that really set the standard for concurrent chemoradiation, the median survival in that study was only 17 months. Now, both of these arms are consistently in the 20-month range. Some of that is, of course, stage migration and PET that Corey had mentioned a few minutes ago, but some of it may be technology too. So now IMRT, which is an advanced way to deliver the radiation therapy, really pinpointing radiation, making the treatment more conformal, treating a smaller area, fewer normal tissues, that was used in about half of the patients in the RTOG, the newer study 0617, whereas it really didn't exist for lung cancer treatment in 9410. So what actually caused the difference in survival? If it wasn't related to esophagitis, it wasn't related to acute deaths from the treatment. And this is something that was really interesting. This was actually hidden in the supplemental data in the Lancet Oncology publication. It was their multivariate Cox model showing what factors were significantly associated with survival. And if you look, so radiation dose was, performance status, PET staging, gender, histology, all the things that we would expect with locally advanced non-small cell lung cancer were considered. The factor that was actually statistically the most important factor predicting for survival was the actual dose that the heart received. This is really groundbreaking and changed a lot of paradigms. So this was just published earlier this year, and it sort of sent a lot of shockwaves through radiation oncology. Reason being, as we heard earlier in the last sessions, lung radiation toxicity tends to be our most difficult thing we deal with. So we can cause radiation pneumonitis, fibrosis, all those things can decrease quality of life, potentially lead to deaths from treatment. The best way to lower the dose to the lungs was to essentially blast as much dose as you can front to back through the heart. And so that's really what we did for the last 40 years, is we tried to minimize dose to the lungs at all costs, including indiscriminately treating the heart. And this study suggests that we can't do that anymore. So the authors actually said that the heart dose might best explain why patients given 74 gray did worse than patients given 60 gray. And when you look at the doses received to the heart, comparing 60 gray versus 74 gray, significantly more dose was delivered to the heart in the higher dose arms. What about different modalities? Well, I keep using this study as sort of a focus. There have been several other reports that have suggested this as well, but looking at a secondary analysis of this, they performed as a secondary endpoint quality of life on this study. They looked at a subset of 314 patients that completed quality of life surveys before, 3 months after radiation, and 12 months after radiation, and they compared the different arms. What they showed is that 74 gray had a significantly higher decline in quality of life compared to 60 gray. They also showed, very importantly, and this has been shown in the stage 3 setting and significantly in the stage 4 setting, which we'll hear about tomorrow, that quality of life predicted for overall survival. So quality of life declines, those patients had worse survival. Quality of life declines were more significant in 74 gray, so is the 74 gray then leading to more deaths by causing significant quality of life declines, whether it's from pulmonary or cardiac or esophageal toxicity? The other interesting thing that came out of this was the modality. So you heard me talk about intensity modulated radiation therapy before. It's really, in most centers, the most advanced way to deliver radiation therapy to the lung. What this study showed is it still wasn't quite the standard of care when the study started in 2006. And so because of that, more patients with larger tumors got intensity modulated radiation therapy, more advanced stages, basically harder tumors to treat, preferentially received IMRT. Despite this, IMRT patients had less declines in quality of life compared with 3D conformal patients. And again, we saw that quality of life declines predicted for overall survival. So does this suggest that IMRT improved overall survival? What else came out of this study? So this was actually just presented at ASTRO last month, the main radiation oncology annual meeting. So in addition to IMRT improving quality of life and being associated with better overall survival, it also significantly reduced the rates of pneumonitis, and pretty significantly. So grade 3 or higher pneumonitis rates were more than cut in half when using IMRT compared to 3D conformal. And again, that's despite treating larger tumors that we'd expect to have higher rates of pneumonitis. It also decreased the requirement of patients to need oxygen after the treatment from late fibrosis effects. Of course, we talked about decreasing the dose delivered to the heart, which was also associated with survival. And then it also allowed more patients to complete consolidative chemotherapy. We heard of potential benefits of consolidative before, but fewer toxicities, more patients were able to be compliant with intended treatment, and importantly, also reduced hospitalizations and ICU admissions. So it looks like IMRT, at least from a technology standpoint, can improve outcomes compared to 3D conformal. There have now been a couple of studies in locally advanced non-small cell lung cancer that suggest that as well. And so we've talked about the heart and focused on that, and then just one slide on the lungs. Why is radiation pneumonitis so important? So this is a pooled analysis, a systemic review of over 800 patients from 12 centers, of which we contributed data for, looking at factors that predicted for pneumonitis. And if you look, this number, 30% of all patients treated with chemoradiation will get grade 2 or higher pneumonitis. So that's steroids, that could be oxygen, and other things as you get to higher grades, inpatient admission. So it's a high number. Nearly 1 in 3 patients are going to need some type of treatment for radiation pneumonitis. We know that the dose that we deliver to the lungs predicts that. We know certain chemotherapies make that more likely. But intensity modulated radiation therapy, being able to do something about that, 1, can improve quality of life by decreasing the rates of these. But 2, this is the even more shocking number. We sort of take this for granted in the way we treat patients, but 2% of all patients that we treat with concurrent chemoradiation will actually die from radiation pneumonitis. That's a shocking number, and it's not a number that in radiation oncology we see in any other disease site, but this is an expected toxicity just related to the lungs. So again, can we do anything to decrease that? And IMRT appears to be one of them. What about in the tri-modality setting? Well, we historically have not wanted to deliver radiation therapy after surgery and adjuvant chemotherapy, largely based on what was the PORT meta-analysis. This was a pooled analysis, now over a decade old. 2005 was published as an update, showing that basically giving adjuvant radiation therapy after surgery actually led to survival decrements. Now, this study had significant sort of problems at the time. The radiation technology really wasn't able to handle a postoperative treatment. A lot of these treatments use cobalt, which we don't use in the US anymore, and other factors. But the reason I point this study out is it actually showed the causes of death in this updated analysis. And it showed that if you deliver adjuvant radiation therapy, you're less likely to die of your lung cancer, but you're more likely to die of other factors. And those other factors were traced back to be cardiac and pulmonary causes. So there have been several studies in both the definitive and the trimodality setting that adjuvant radiation therapy or definitive radiation therapy can lead to increase in toxicity and increase in non-cancer related deaths. So again, how do we make radiation therapy safer? How do we make it now improve outcomes? And these are probably the best data we have to suggest that it is a safer outcome, and really because of IMRT. So these are 2 modern population-based studies, again looking at the adjuvant setting. One a SEER meta-analysis, one a National Cancer Database analysis of over 7,000 patients, over 4,000 patients. Both of them showed adjuvant radiation therapy tended to be given in patients with bigger tumors, more advanced stages. Both of them showed a significant survival benefit. So we took what historically was a survival decrement by giving adjuvant radiation therapy, and now we're consistently showing a survival benefit. Some of that is, yes, the technology going from a cobalt machine to a linear accelerator, but that survival benefit wasn't really realized until we started to do 3D conformal radiation and especially intensity modulated radiation therapy, which a good number of the patients on the National Cancer Database study had. What about the other way, in the neoadjuvant setting? Well, we saw this data before. This was the intergroup trial published by Albane looking at concurrent chemoradiation followed by surgery, or concurrent chemoradiation to a definitive dose of 61 gray, with patients all getting consolidated radiation therapy. And we saw these two graphs too, but I'm going to present them in a little bit of a different light. So we know that if you have trimodality therapy, there's a clear progression-free survival advantage. And that makes a lot of sense. So we saw that only 38% of patients in historical RTOG studies have long-term local control. Well, that's pretty lousy. Surgery can do a much, much better job, particularly for larger tumors, greater than 5, greater than 7 centimeters. So it's no surprise that the progression-free survival is significantly better in patients having surgery. This is a very telling number. The long-term progression-free survival at 5 years was more than doubled in patients that had surgery. So radiation may not be adequate to control larger tumors, but certainly when you combine surgery with it, we may have a better shot at controlling tumors. We already talked about local control and tumor control in this setting, improving survival, but we didn't see an overall survival benefit in the study, potentially again because of toxicities and some of the other concerns that we're seeing in this study. So the overall survival benefit from improved local control appeared to be offset by perioperative mortalities in the study. Can we do something to improve the way radiation is delivered to not see as much toxicity? This is the study that Harvey was mentioning that was led by the Maryland group. It was an RTOG study, RTOG 0229. It was a phase 2 trial of 57 patients with pathologically proven N2 or N3 disease, all stage 3, treated with induction chemo followed by concurrent chemoradiation, and then went on to have surgery. What the study showed is they were able to treat to a definitive dose of 61 gray relatively safely. And by doing so, it improved outcomes compared to every other trimodality trial that we've ever seen. So first, the pathologic clearance was 63% in the mediastinum. So that compares to 15 to 40% that we've seen in other studies. So by giving a higher dose, we can improve the clearance. We already heard earlier today that pathological clearance is the factor most important as far as overall survival goes in the trimodality setting. The study also showed a 2-year overall survival of 54%, and in patients with a pathologic clearance, 75%. So very, very high survival numbers, and toxicity was very manageable, only 14% with a higher grade pulmonary toxicity. So by doing advanced modalities, and again, this was led by Maryland, was one of the earlier adopters of intensity modulated radiation therapy, we may be able to integrate trimodality safer than historically was able. The last modality and thing we'll end with is proton therapy. So I apologize about the physics slide. Now you guys know how I feel every time I look at a molecular sort of analysis chart that you guys show in all the medical oncology talks. So this is basically looking at the dose distribution of radiation therapy. So if we're trying to treat a tumor somewhere on the order of about 20 centimeters deep into a patient, with traditional photon radiation therapy, we send the radiation in, we reach about 100% of the depth, a couple of centimeters into a patient, and then as the radiation actually travels to the patient, we lose radiation. So you're only getting a fraction of the radiation to the area where the tumor is. We account for that by treating with multiple fields to increase the dose, but unfortunately, now we're essentially giving 100% of radiation through and through a patient. So all the normal tissues are getting irradiated. The advantage of proton therapy is we're able to send the radiation in, typically at a much lower dose to the skin and all the organs in front of a tumor, treat the tumor to 100% of the dose that we want, and then tell the radiation beam to deposit all of its energy. So we get no dose beyond that area. So what that is now we're able to give less radiation to the normal tissues before the tumor, less radiation to the normal tissues after the tumor. In fact, no radiation to the tissues after the tumor. So why use proton therapy in the chest? Well, several reasons. One, as you see, there's less normal tissue irradiated that potentially can allow fewer side effects. Two, we can now potentially consider dose escalation, which I think is important, but maybe not in an unselected fashion because of the toxicities that we see with it. Three, we may be able to now more safely allow for trimodality therapy, or at least bimodality therapy without as many toxicities. And then retreatment as well, which we'll spend a slide on talking about. If you look at the dose distribution for radiation of proton therapy, This is a patient with a T4 tumor that's invading the heart. So no matter what we do with intensity modulated radiation therapy, you can see there's significant dose going to the entire heart. The entire ipsilateral lung is getting some radiation, the esophagus. And this is as conformal of a plan as we can get. With proton therapy, we're really able to completely spare, so the esophagus getting zero dose, the spinal cord getting zero dose, and most of the heart, which now we know is important as far as survival, is really limited from a radiation standpoint. Just another example, this is post-op. With IMRT, we're really spreading around a lot of dose. With protons, we're really able to limit the dose, less dose to the heart, the lungs, etc. So why is this important? And just sticking with the heart theme, this was a study of over 500 patients done by MD Anderson looking at heart doses by modality. When we use 3D conformal radiation, the mean heart dose delivered is 22 gray, IMRT is 15 gray, proton therapy only 6 gray, so we're really treating much, much less of the heart with proton therapy. This was a randomized study, still unpublished, but going to be coming out soon. It's the first randomized trial looking at proton therapy versus photon therapy for lung cancer. And it showed whether you looked at the average dose received by the heart, a small amount of dose, 5 gray delivered to the heart, there's consistently, for every single patient, a significant reduction in the heart dose with proton therapy. So can that equate to a survival benefit? Well, maybe. I don't know how to go back, but on the last study, what the MD Anderson group also looked at is across that 500 patient population, the dose to the heart actually also significantly impacted survival. So patients treated to higher doses to the heart, even controlling for extent of nodal disease and other aspects, significant improvement in overall survival. So what clinical data do we really have to support proton therapy? Well, this is one. This is a phase 2 trial, 44 patients with stage 3 as opposed to stage 2 and 3, which is what most locally advanced trials include. All these patients were treated to 74 gray. So this is interesting. The same dose that was too much with photons and resulted in patients dying, unfortunately, from the treatment, this was their standard dose with proton therapy, and it resulted in a median overall survival of 29.4 months. It's actually the best survival that's ever been reported in a bimodality trial for locally advanced lung cancer. So 29.4 months. Two other things that were interesting that came out of this. The local failure was only 20%. We're typically seeing that be 30, 50, or more percent, and only 20%. So if we can deliver high doses, 74 gray or more, potentially we improve local control. Do proton therapy allow us to do that safer? The answer is it looks like yes. Only 2% of patients had a grade 3 pneumonitis. Again, we would expect that to be about double digits. The only other clinical data that we have so far with locally advanced lung cancer are these, two of which are groups from Asia and the others here in the US. And consistently, you can see that we're able to treat into the 70 to 74 gray range with very minimal toxicity. Across this toxicity column, all the toxicity to the lungs, the esophagus, tends to be in the single-digit range. So there are two trials that are currently open that'll try to help us answer, is proton therapy ready for prime time? Should it be really considered as a replacement for photon therapy? One is through the RTOG. It's randomizing patients to 70 gray with photons or protons along with concurrent chemoradiation. And they're predicting a survival benefit in two ways. One, by allowing for a higher dose with proton therapy. If dose constraints aren't met with this trial, the doses are going to be dropped. And the thought is that proton therapy will more safely be able to treat these normal structures that we can't do with photons. The second way is simply by reducing toxicities. So we now really can see that heart, lungs, they're really associated with survival if we cause toxicity to those organs, and proton therapy may be a safer way to do that. The last study is by the Proton Collaborative Group, and this is an interesting study. So we know a lot about stereotactic body radiotherapy and increasing the biological dose for early stage lung cancer. If we could do something similar in the locally advanced setting, can we improve outcomes as well? So this study is basically keeping that standard 60 gray amount, but trying to do it in fewer fractions. So biologically, it's a stronger and more significant dose to the tumor. I'll skip that in the interest of time. And then lastly, the last two slides just focus on reirradiation. And I think this is probably the biggest benefit of a technology improvement. So reirradiation, by definition, these are patients with bad biology. Local failures we know happen in up to about 50% of patients with locally advanced non-small cell lung cancer. And isolated local regional failures happen in about 20 to 30% of people. If we treat them with surgery, with radiation, potentially we can cure them, but usually we don't consider those modalities because of the toxicity of either reirradiation or doing surgery after chemo and radiation. But unfortunately, chemotherapy we know is not going to be curative in these patients. We can consider immunotherapies now, and that's probably where we're going to be going for this patient population. But with historical data, cytotoxic chemotherapy, progression-free survival is typically on the order of 4 or 5 months in this patient population. Proton therapy may allow us to retreat patients safer since we don't have as much normal tissue being irradiated. This is a list of prior reirradiation studies in lung cancer for locally advanced patients. And you can see this top group of studies, all these patients were treated initially to 50, 60-ish gray of radiation, so a standard chemoradiation course. This top group of studies, the investigators didn't feel that they could safely deliver a high dose again, and rightfully so with the toxicities. But unfortunately, by delivering low palliative doses of radiation, consistently the survival is 5 months, 5 months, 5 months, 5 months, 5 months. By treating the higher doses into the 50 gray with the second course of radiation, now we're starting to get survival benefits. So I like to give this example, and then we'll just close with a little data that we have amassed at Penn. But this is one of the first patients I actually treated at Penn. This is a patient that had surgery for T2N2 disease, had a right paratracheal node that was identified at the time of surgery, had adjuvant chemotherapy. Because he had N2 disease, we planned to do adjuvant radiation therapy, was re-imaged prior to radiation and already had a right paratracheal recurrence. So this grew during chemotherapy after it was already resected. Instead of treating to an adjuvant dose of 45 or 50 gray of radiation, the patient at another facility was treated to 66 gray. So I got a high dose. Spinal cord really got as much as it can tolerate with that first course of radiation. And what we saw is the patient had a great response initially. 3 months later, paratracheal nodes seemed to be getting smaller, less avid. 3 months after that, so 6 months after radiation, already started to have progression. He was started on second-line chemo and progressed during chemotherapy. So he's referred to me for reirradiation with proton therapy. So this is biologically as bad of a tumor as you can get. It was resected, it's had 2 courses of chemotherapy, already radiation, and all of this is within about a 10-month time period where it's now had its 3rd recurrence. We treated with proton therapy alone, no chemotherapy with it, and he's now 4 years out, alive and well. So this kind of story, while not sort of the norm, certainly led us to consider, should we do prospective studies in this? And we've done just that. So we started a prospective multi-institution study looking at proton reirradiation. We've now accrued close to 50 patients, majority at Penn, but also in Chicago and Oklahoma City proton therapy centers. And what we've seen is this is sort of the most shocking point, and this is where maybe technology does beat biology. All of these patients, 49 out of 49, had a local failure after chemo, all heavily pretreated. In theory, these tumors should be more radio-resistant at this point since they already failed radiation. Only one of these patients over the last 5 years have ever failed in field. So it looks like proton therapy and doing high doses of reirradiation can now change the natural history of these patients. So I'm going to just end with that. There's some other technology advances with PET imaging and ways to account for tumor motion, whether it's mitigating motion, whether it's minimizing tumor motion, doing daily imaging. All of these things can really help us to decrease the margin that we're treating with patients and decrease side effects. So conclusions, concurrent chemoradiation we know is a standard of care, but that as well as altered fractionation really has only made incremental improvements in local control. We know that local control can impact overall survival with locally advanced lung cancer, so we need to figure out ways to improve local control. Dose escalation is one, but the toxicity tends to be very high when doing so with photon therapy. Things like intensity modulated radiation therapy, proton therapy may more safely allow for dose escalation. There's a lot of data now that intensity modulated radiation therapy can improve quality of life, can decrease hospitalizations, decrease pulmonary toxicity, and proton therapy similarly can allow for an advantage in a lot of these things, and importantly, maybe more safely integrated with surgery and other modalities. And then doing things like PET and image and motion management can help us to treat smaller areas that will further reduce side effects. Thank you.